Now let's talk about the female internal genital organs. So these include the ovaries, the uterine tubes, the uterus, and the vagina. So first of all, let's talk about the ovary. So there is going to be one ovary on each side of the pelvis, and what are the diameters of the ovary? They are going to be 1.5 x 0.75 inches. So the ovary is going to attach on the back of the broad ligament by mesovarium. Through the mesovarium, the ovary is going to attach to the back of the broad ligament. Let's talk about another relation, that is MLS. So the part of the broad ligament which is present between the mesovarium and the lateral wall of the pelvis is the suspensory ligament of the ovary. Now let's talk about the round ligament of ovary, which is the remains of the upper part of the gubernaculum, which connects the lateral margin of the uterus to the ovary. The ovary lies against the lateral wall of the pelvis in a depression called the ovarian fossa, which is bounded by external iliac vessels above and internal iliac vessels behind. The position of ovaries is highly variable. They are often going to hang down in the rectouterine pouch, which is the pouch of the Douglas. During the pregnancy, there is going to be enlargement of the uterus, which is going to pull the ovary upwards into the abdominal cavity. However, after birth, the broad ligament is going to lax, okay? So ovary is going to take up a variable position in the pelvis. And thin fibrous capsule, which is going to be called as tunica albuginea, is going to surround the ovaries. Also, germinal epithelium or modified area of the peritoneum is also going to cover the tunica albuginea externally. However, the name of germinal epithelium is confusing. It is not related to oocytes, like as in germinal. So, oogonial development before birth from primordial germ cells, that is not related. So, what happens before puberty? Before puberty, the ovary is going to be smooth. Corpora lutea are going to degenerate, which is going to lead to scarred ovary after puberty. And after menopause, what happens is that ovary is going to get shrunk and the surface is going to be pitted with scars. Now let's talk about the function of the ovary. It is used to produce ova or female germ cells, and female sex hormones, which are estrogen and progesterone, are also produced by the ovary. So let's talk about the blood supply of the ovary. So abdominal aorta is going to give off an ovarian artery at the level of L1. Let's talk about the ovarian vein. Right ovarian vein is going to drain into the inferior vena cava. Left ovarian vein is going to drain into the left renal vein. Relation was in the testicular vein in males. Now let's talk about the lymphatic drainage of the ovaries. So they are going to be drained from the para-aortic lymph nodes at L1, and the nerve supply is going to be from aortic plexus, and it is going to accompany the ovarian artery. Now let's talk about the blood supply. Okay, so blood supply, nerve supply, lymphatics are going to pass over the pelvic inlet, and they are going to cross the external iliac vessels and reach the ovary through the suspensory ligaments. So you can remember all of this by PEO, and also through the suspensory ligament, which is the lateral end of the mesovarium. Okay, so now let's talk about vessels and nerves, which are going to enter the hilum of ovary through the mesovarium. Now let's talk about something which is called the uterine tube. So there are going to be two uterine tubes which are going to be present on each side. They are each 4 inches long. They are going to lie in the upper border of the broad ligament or the broad ligament. Each is going to connect the peritoneal cavity in the ovary with the uterus. Parts of the uterine tubes, there are like 4 parts. I can remember this with AIII, which is infundibulum, ampulla, isthmus, and intramural part. So now, first of all, let's talk about the infundibulum, which looks like a funnel. It is at the lateral end and it is funnel shaped. It is going to project beyond the broad ligament and it is going to overlie the artery. The free edge of the infundibulum has finger-like processes, which are called the fimbriae, which are draped over the ovary. Now let's talk about the ampulla. So ampulla is the widest part of the uterine tube. Now let's talk about the isthmus. Isthmus is the narrowest part of the uterine tube and it is lateral to the uterus. Now let's talk about the intramural part. It is the segment that pierces the uterine wall. Now let's talk about the blood supply to the uterine artery. It is supplied by uterine artery from internal iliac artery as well as ovarian artery, which is a branch of abdominal aorta. Now let's talk about veins. Veins are going to correspond to the arteries. Now let's talk about lymphatic drainage, which is through the internal iliac and the para-aortic lymph nodes. Now let's talk about the nerve supply. So sympathetics and parasympathetic nerves for the uterine tube are going to arise from the inferior hypogastric plexus. Let's talk about the uterus. So uterus is a hollow, pear-shaped organ and it has thick muscular walls. In young nulliparous adult who have not had babies yet, it is 3 inches long and 2 inches wide and 1 inch thick. So 3-to-1 rule. Now let's talk about the divisions of the uterus. So you can remember this with FBC, which is the fundus and a body and the cervix. Now let's talk about these divisions with respect to the uterine tube. So the fundus is going to lie above the entrance of the uterine tube, the body is going to lie below the entrance of the uterine tube, and cervix is the low, narrow part of the uterus. It is going to pierce the anterior abdominal wall of the vagina. So CAV. Cervix is going to be divided into two parts, supravaginal part and vaginal parts of the cervix. Now let's talk about the cavity of the uterine body. Cavity of the uterine body, as we can see here, it is triangular, and it is triangular in the coronal section. However, in the sagittal section, it is just like a cleft. The cavity of the cervix, or the cervical canal, is going to communicate with the body of the uterus through the internal os, and the cervical canal is going to connect with the body of the vagina through the external os. Before a woman has had a baby, external os is circular. However, after a baby, like in Paris women, external os is slit-like and vaginal part of the cervix is larger. So internal os in Paris women is divided into an anterior lip and posterior lip, and it is present in the form of a transverse slit. Now let's talk about the uterus. Uterus is covered with peritoneum except anteriorly below the level of the internal os, where the peritoneum passes forward onto the bladder. Laterally, a space is going to exist between the attachments of the layers of the broad ligament. Myometrium is thick and it is made up of smooth muscle which is supported by connective tissue. Endometrium is the mucous membrane which is lining the body of the uterus. Endometrium is continuous above with the mucous membrane lining the uterine tubes, and it is continuous below with the mucous membrane lining the cervix. So, endometrium is directly applied to the muscle. There is no submucosa. Extensive changes during menses due to the hormones of the ovaries are going to be there. So supravaginal part and vaginal part of the cervix. Supravaginal part of the cervix is surrounded by visceral pelvic fascia, or the parametrium. Uterine artery crosses the ureter in the visceral pelvic fascia on each side of the cervix. Now let's talk about the relations of the uterus. They're very, very, very important. Please remember them. So anteriorly, what do we have? And posteriorly and laterally, what do we have? So remember the relations to an apple. So anterior, posterior, lateral. Okay. So anteriorly, we're gonna have utrovesical pouch, or a UV pouch. And also, we are also going to have superior surface of the bladder. So you can remember this with USP. Also, the vaginal cervix is related to the anterior fornix of the vagina. Okay. And whatever we're going to have posteriorly, we're going to have RU pouch, or rectouterine pouch posteriorly. And rectouterine pouch, or the pouch of Douglas, with coils of ileum or sigmoid colon within it. Let's talk about laterally. What happens laterally? Broad ligament is present, and uterine artery and uterine veins are present. Now let's talk about supravaginal cervix and vaginal cervix. Supravaginal cervix is related to ureter, and vaginal cervix is related to the lateral fornix of the vagina. Supravaginal part of the cervix is related to ureter as it enters the bladder, and the vaginal cervix is related to lateral fornix of the vagina. Uterine tubes are going to enter the supralateral angles of the uterus, and the round ligaments of the ovary and the uterus are attached to the uterine wall just below this level. Now let's talk about the positions of the uterus. So long axis of the uterus is bent forward at a 90-degree angle to the long axis of vagina. This is the anti-version of the uterus. This is the most normal and most common position. And kind of position is that long axis of the body of the uterus is bent forward at the level of the internal os with the long axis of the cervix. UC. This is the anti-flexion of the uterus. Erect position with the bladder empty. The horizontal position of the uterus is present. In some women, fundus and body of the uterus will bend backwards onto the vagina as they lie in rectouterine pouch, or the pouch of Douglas. This is a retroverted position, and when the body of the uterus is bent backwards onto the cervix, this is a retroflex position. Now let's talk about the function of the uterus: reception, retention, nutrition of the fertilized ovum. Okay, now let's talk about the blood supply of the uterus. Uterine artery is gonna come from the internal iliac artery. Let's talk about this in more detail. It is very easy. The uterine artery is going to pass medially in the base of the broad ligament. You can remember this with MBB. And then it is going to cross above the ureter at right angle. So it is going to pass medially in base of broad ligament, and then it is going to cross above the ureter in right angle, and then it is going to reach a cervix at the level of the internal os, and then it is going to anastomose with something. So then this artery is going to ascend along the lateral margin of the uterus within the broad ligament, and it is going to anastomose with the ovarian artery, which supplies the uterus. The branch of uterine artery, which is a small descending branch, is going to supply the cervix and vagina. Now let's talk about the lymphatics of the uterus. So the fundus of the uterus is going to be drained by the para-aortic lymph nodes at L1, and the body of the cervix is going to be drained by internal and external iliac lymph nodes. Few lymph vessels are also going to follow the round ligament of uterus through the inguinal canal and drain into the superficial inguinal lymph nodes. Now let's talk about the nerve supply of the uterus. So it is also going to be IHP, which is inferior hypogastric plexus, synthetic and parasympathetic nerves. Now let's talk about the support to the uterus. This levator ani muscle tone, and also local condensations of the pelvic fascia, which are going to form three important ligaments. Now let's talk about levator ani and perineal body. Levator ani form a broad muscular sheet which is across the floor of the pelvic cavity. Here we can see the levator ani. So levator ani and PF, pelvic fascia, upper surface, are going to support the pelvic viscera, and they will resist intra-abdominal pressure transmitted downwards through the pelvis. Medial edge of the anterior part of the levator ani will attach to the cervix by pelvic fascia here. Okay, this is it. Some fibers of the levator ani will insert into a fibromuscular structure, which is called the perineal body. This maintains the integrity of the pelvic floor. If the perineal body is damaged during childbirth, pelvic viscera will prolapse. Perineal body lies in the perineum between the vagina and the anal canal. Perineal body is slung up to the pelvic walls by the levator ani, and it supports the vagina and indirectly supports the uterus. Now let's talk about facial ligaments. So facial ligaments are SPC of PF on LA. They are subperitoneal condensations SPC of PF, pelvic fascia, on LA, levator ani, upper surface. They are going to form 3 ligaments. They attach to the cervix and vaginal vault. They support the uterus and they keep the cervix in the correct position. So these 3 ligaments are transverse cervical ligaments, pubocervical ligaments, and sacrocervical ligaments, TPS. Now let's talk about them in detail. First of all, we have the transverse cervical ligaments or the cardinal ligaments. These are the fibromuscular condensations of the pelvic fascia, and they pass to the cervix and vagina on the lateral walls of the pelvis. Just remember this. Okay, so this was all. And then let's talk about the pubocervical ligaments. So they are 2 firm bands of connective tissue that pass to the cervix from the pubis, and they are positioned on either side of the neck of the bladder. So please remember, when you remember pubocervical, just remember pubovesical as well, that they are positioned on either side of the neck of the bladder as well, to which they give support. Now let's talk about the sacrocervical ligaments. Sacrocervical ligaments are going to arise from the sacrum, and they are going to consist of 2 firm bands of fibromuscular bands of the pelvic fascia that pass to the cervix and the upper part of vagina from the lower end of the sacrum. They form 2 ridges, one on either side of the rectouterine pouch. So that was their important thing. Sacrocervical ligaments are involved in the formation of 2 ridges on either side of rectouterine pouch. The broad ligaments and the round ligaments of the uterus are lax structures, and the uterus can be pulled up or pushed down for a considerable distance before they become taut. Clinically, they are considered to play a minor role in supporting of the uterus. So they are only going to play a minor role, broad ligaments and round ligaments. The round ligament of the uterus, which represents the remains of the lower half of the gubernaculum, extends between the superlateral angle of the uterus and then goes into the deep inguinal canal and then into the subcutaneous tissue of the labium majus. So you can remember this with SL angle, DIR, and SC tissue of the labium majus. It may help to keep the uterus anteverted and anteflexed, like tilted forward and bent forward, but it is considerably stretched during pregnancy. Now let's talk about the pre-puberty uterus. Fundus and body of the uterus remain small until the puberty, when they enlarge greatly in response to the estrogens secreted by the ovaries. Now let's talk about the postmenopausal uterus, which is going to atrophy and become smaller and less vascular. These changes occur because the ovaries no longer produce estrogens and progesterones. Let's talk about the pregnant uterus. During pregnancy, uterus is going to enlarge greatly as a result of increase in the production of estrogens and progesterone, firstly by the corpus luteum of the ovarium and then by the placenta. At first, it remains as a pelvic organ, but by the 3rd month, the fundus rises out of the pelvis, and by the 9th month, it has reached the xiphoid process. This increase in size is due to the hypertrophy of the smooth muscle, which takes place in the myometrium. It's a smooth muscle and connective tissue, although some hyperplasia also takes place. Role of uterus in labor is that labor or parturition in the series of processes by which the baby, fetal membranes of the placenta are expelled from the genital tract of the mother. Normally, the process takes place at the end of the 10th lunar month, at which time the pregnancy is said to be at term. The cause of the onset of labor is not definitely known. By the end of pregnancy, the contractility of the uterus has been fully developed in response to estrogens, and it is particularly sensitive to the actions of the oxytocin at this time. It is possible that the onset of labor is triggered by the sudden withdrawal of progesterone. Once the presenting part, which is usually the fetal head, starts to stretch the cervix, a nervous reflex mechanism is initiated and increases the force of contractions of the uterine body. Uterine muscular activity is largely independent of the extrinsic innervation. In women in labor, spinal anesthesia does not interfere with the normal uterine contractions. Severe emotional disturbances, however, can cause premature parturition. Now let's talk about the vagina. So the upper part of the vagina, upper half of the vagina has the pelvic floor or pelvic cavity. Lower half of the vagina has perineum, or it is present in the perineum. Vagina has a muscular tube, and it extends upwards and backwards from the vulva to the uterus, VUV. Okay, so it is 3 inches long, and it has anterior and posterior walls, which are normally in apposition, and the cervix is going to pierce the anterior abdominal wall and goes downwards and backwards into the upper part of the vagina. The area of the vaginal lumen around the cervix is divided into 4 fornices. So vagina is divided into 4 fornices around the cervix. We have an anterior fornix, posterior fornix, and right and left lateral fornices. Now let's talk about the relations of the vagina, which are extremely important. So we have anterior, posterior, and lateral relation. So for the anterior relation, please remember someone who is called Bob. For posterior relation, someone called Rap. And for lateral relation, please remember someone called Upu. Okay, so anteriorly we're gonna have BAUB. So bladder above, urethra below. Posteriorly, what do we have? We have Rap. So we have upper one third, middle one third, and lower one third. So we're gonna have rectouterine pouch or pouch of Douglas in the upper one third, and in the middle one third we are gonna have the ampulla of rectum, and in the lower one third, what are we gonna have? We are going to have the perineal body. Now let's talk about the lateral relation. So we have an upper part, a middle part, and then we have a lower part as well. So in the upper part, we are going to have the ureter. In the middle part, we are going to have puborectalis, which is going puborectalis of the levator ani, which is going to run backwards to reach the perineal body and hook around the anorectal junction. Contraction of the levator ani fibers will compress the walls of the vagina together. Now let's talk about the lower part. Lower part has the urogenital diaphragm and the bulb of the vestibule. Now let's talk about the functions of the vagina. So it is the female genital canal. It has excretory duct function because of the flow of menses, and it is a part of birth canal as well. Now let's talk about the blood supply of the vagina, which is through the vaginal artery and which comes from the internal iliac artery and also from the vaginal branch of the internal iliac artery. The veins are gonna form a plexus and drain into internal iliac veins. So for the lymphatics, I have an upper, middle, and lower part. So upper one third is going to be drained by internal iliac lymph nodes and external iliac lymph nodes. Middle one third is drained by the internal iliac lymph nodes, and the lower one third is drained by superficial inguinal lymph nodes. Now let's talk about the nerve supply. Nerve supply is inferior hypogastric plexus and supported the vagina is through LUP. So L is for the levator ani muscle and the ligaments of the vagina, which are basically the transverse cervical, the pubocervical, and sacrocervical ligaments. They are going to support the upper part of the vagina and attach to the vaginal wall by pelvic fascia. Now let's talk about the middle part of the vagina, which is supported through the urogenital diaphragm, and the lower part of the vagina is supported by the perineal body, which supports especially the posterior wall. Now let's talk about the peritoneum in female. So parietal peritoneum is going to extend down from the anterior abdominal wall onto the upper surface of the bladder, so AB, and then it is going to turn backwards onto the anterior surface of the uterus at the level of the internal os, so AU, and then you gotta remember UV as well. So a shallow utrovesical pouch is created because of that. And then please remember BF, because it is going to pass over the anterior surface of the body and the fundus of the uterus, and then it is going to go down. So please remember P for that. So it is going to go downwards over the posterior surface. Then please remember that it is going to cover the upper part of the posterior part of the vagina, and it is going to go forwards towards the rectum. So as a result of that, rectouterine pouch is formed. Okay. Then at the end, we are going to have rectouterine pouch. So in females, rectouterine pouch is the lowest part of the abdominal pelvic peritoneal cavity in the erect position. Now let's talk about broad ligaments. So broad ligaments are two layered folds of peritoneum that extend across the pelvic cavity and connect the lateral margin of the uterus to the lateral pelvic walls. They are going to cover the body and the fundus of the uterus, uterine tubes, and ovaries. So let's talk about their relations. So we have a superior relation and inferior relation. Okay, so superiorly, the two layers are continuous to form a free edge, and inferiorly, at the base of the ligament, layers are going to separate to cover the pelvic floor. As I have told you that these layers are separated, so the space between them is going to be called as a parametrium, which is a connective tissue that fills the gap between the separated layers, which is present inferiorly of the broad ligament. The part of the broad ligament which is attached to the lateral margins of the uterus is the mesometrium. Now let's talk about MOB, which was a relation. Varium and the ovary are attached to the posterior part of the broad ligament, and lateral to the attachment of the mesovarium we have suspensory ligament of the ovary, and part of the broad ligament between the uterine tube and the mesovarium. So a part of the broad ligament between tube and mesovarium, T and M, is going to be called as this is the mesosalpinx. Now also remember the uterine artery is going to cross the ureter at the base of the broad ligament. So this was the water and the bridge relation. So let's consider ureter to be the water, and let's consider the bridge to be the uterine artery. What does it have? What are the contents of the broad ligament? It has RUPE contents. So it is going to have a round ligament of the ovary and round ligament of the uterus, which are the remnants of the gubernaculum. And it has a uterine tube, which is at the upper free border, and it has a paraoophoron and epooophoron, which are basically vestigial structures. And paraoophoron is going to lie in the broad ligament lateral to the uterus, and epooophoron is present above the mesovarium. Both are remnants of the mesonephros.